So hello, let's get started the last session. The last session will be, for the first two presentations, will be a debate about the adjuvant use of immunotherapy, but in general treatments for renal cell cancer and urothelial cancer. So we will start with the pros, and it will be Yüksel Yurun from Ankara who will try to convince us about the pros, probably, of the immunotherapy. And we have this poll, and the poll is about a 69-year-old lady with a PT2 grade 3 N-node, M-node, Leibovitch 6 non-sarcomatoid renal cancer who got a nephrectomy. She's PS1, and she has acquired rheumatoid arthritis. So the options were for follow-up or adjuvant pembrolizumab. I think the most of the colleagues voted for the follow-up. You can still vote on the Slido.com platform. You can ask for your questions there. Please post your questions before the end of the presentation, otherwise it will be difficult to ask to the colleagues. Yüksel, please come in. Thank you.
It's really a great pleasure to be here. Thank you for such a wonderful meeting and organization. I will try to summarize and convince you in 15 minutes. And debate, of course, I like debate. And immunotherapy in both adjuvant RCC and urothelial carcinoma. This is my disclosure slide. Okay, in the localized disease, what are the goal? Actually, most of the time, our goal is to reach a cure. In most of the patients, it may be possible with only surgery, but we know for some patients, we need additional treatment, but not for all. Let's say we don't have chance for the cure, but maybe we can delay the relapse. At that time, we need systemic treatment after the nephrectomy, like a sunitinib pembrolizumab, which shows disease-free survival advantage when comparing with placebo, but yet we don't have any treatment with overall survival benefit. But the problem, when you give treatment during the relapse, if still there is a chance to reach same benefit, it means you put some patient under the unnecessary treatment and treatment toxicity. So you need to decide very well. I will start with two cases. This is one of my first case, 52-year-old male and right radical nephrectomy, clear cell carcinoma with 6 centimeter tumor, no lymph node metastasis, and grade 2. The second is 44-year female patient, grade 3, more than 10 centimeter tumor and lymph node positive. And the question is, which patient has high risk of recurrence? Of course, the answer is 2, but in the real life, result is different. Case 1 presented with like a supraclavicular lymph node, and this is the CT scan, and also biopsy confirm clear cell carcinoma of patient. We know in the localized disease, the gold standard is nephrectomy, even partial or total nephrectomy, but after the surgery, depending on the stage of the patient, up to 40% of patients will face with recurrence, and most of those recurrences will be seen in first 5 years, and lung, bone is most common part of the relapse. We show this graph again. Let's see in other side. In the intermediate disease, the risk of relapse is 20%, but when you go M1 with no evidence of disease, the risk increase up to 80%. Okay, the question is, adjuvant treatment is necessary? For some patients, yes. Answer is definitely yes. But the previous trial with interferon, with other trial, with girentuximab, all was negative. We don't have trial, let's say, until 5 or 6 years, any effective adjuvant treatment for the kidney cancer. The problem, we can say there is or there was no effective adjuvant treatment. We can select the right patient, or maybe the treatment duration is not sufficient, because we learned from the gastrointestinal stromal tumor adjuvant trial, giving 3-year imatinib is better than 1 year. So we have some problem and some question to define and to find. We have some prognostic factor. It's very well defined in previous session, tumor size and other things, but none of them is like a real litmus test. You cannot do the test and have a precision result. It is not, none of them is really perfect. We have 4 immunotherapy trial for adjuvant, and also actually one of them is like a perioperative trial for kidney cancer, but we can say we have a 4 trial, and all have different inclusion criteria, patient characteristic, histology. So it is not really good to compare all trials with each other. They are not head-to-head trial. But let's look in detail. This is CheckMate 904 study. In ITT population, there is no difference between Nivo/Ipi versus placebo. But in the subgroup analysis, patient with T4 disease, sarcomatoid features, and high PD-L1 may get benefit from the adjuvant treatment. This is the only positive trial up to now what we have. It's like a Keynote 564, and we have long-term result, at least for 2.5 years, for 30 months, and we all see disease-free survival benefit at 2 years. It's like a absolute difference is more than 12%, which is really nice, but still we don't have overall survival benefit. Of course, the magnitude of benefit is depends stage of the disease. When you start from intermediate disease, go high, go M1, no evidence of disease, and sarcomatoid disease, the magnitude of benefit is much higher than the intermediate or high-risk disease. And this is the survival curve. Still, there is no survival difference. There is sign, there is trend, but we need to wait. This is still early. But when you come to the adjuvant trial, it's really hard to convince patient, because the toxicity management, I believe we see it is harder than the metastatic disease, because in metastatic disease, patient always want to stay at the trial, but during the adjuvant trial, more patient go out of the trial because of the toxicity, because there is no evidence of disease, and quality of life is much important, I think. But when we look for the quality of life data, actually there is not big difference between pembro and placebo. It means you can preserve also quality of life. Yes, we say, of course, we need adjuvant treatment for some patients, but how can we define those patients? Who are those patients? This is the important questions for us. And as I said before, really we don't have litmus test for kidney cancer to define which patient will get better treatment option. We have different prognostic score. One is 16 gene prediction recurrence score, which is done by Brian Rini and Bernard Escudier. And I think here is important for me. You see the score and the T stage, it's not always correlated with each other. Like our patient I presented at the beginning, some patient with low stage may higher risk. So only classical anatomical stage may not tell us all the thing about the risk of the disease recurrence. We may need further test. And the other, we know von Hippel-Lindau mutation is occurred maybe in more than 75–80% of the patient, some hereditary, some sporadic. But if you have additional mutation beside VHL, let's say only VHL, the purple one is VHL plus 3 different mutation, the risk of recurrence increase. So it may be helpful to define which patient get more benefit from adjuvant treatment. And this is the summary slide from our latest review, we see one positive trial with tyrosine kinase inhibitor and one from the IO, and all other trials go, unfortunately, negative. Still, we don't have overall survival benefit. Both studies show us disease-free survival, but it is not easy always to show overall survival benefit, and it takes time. Should we always wait until that time? Because we already know some of those patients really need adjuvant treatment. Let's summary for kidney cancer. Of course, in localized disease, gold standard is still nephrectomy, local treatment. However, we all know it's not sufficient, at least for, let's say, 1/3 or half of the patient, depending on the stage. The need for adjuvant therapy is obvious. However, it's still controversial because at least half of the patient doesn't need the treatment. So we will put them under unnecessary treatment and toxicity. And disease-free survival, of course, it is not gold standard for adjuvant treatment. We all want to see overall survival, but also for overall survival, there is several confounding factors. So up to now, only we have disease-free survival. There is no OS benefit, but it should be, of course, primary endpoint for adjuvant treatment. And for that, we should inform our patient that there is no major data about overall survival and biomarkers not available for this. And patient selection, like a risk scores, molecular score, MET polymorphism, or 16-gene risk score, may be helpful in the future, but not yet. And still, we don't have really reliable biomarkers in the clinical practice.